Well, hello, everyone. Great to be with you on this April 23rd, Friday at 1:20 p.m. Central Standard Time. Mike Ackerman here with you, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and the Windland Smith Rice Sudden Death Genomics Laboratory. And on behalf of Alice Laura, the CEO of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, it's great to be here. This is our 60th episode, and whether it's Facebook Live or YouTube or wherever you're following us, Facebook, YouTube, Twitter, great to have you. I know I'm going to see some of my Friday afternoon friends or Saturday, April 24th morning friends down under. Dr. Samsarian, are you and your team and patients awake yet? But wherever you are across the globe, thanks for joining in. It's going to be a great program. I'm soon going to bring to you a great guy, a good friend, special friend, and a colleague from Vanderbilt University, Dr. Prince Kannankeril. And we're going to have a fun conversation about CPVT. This for you out there where your monogenetic heart rhythm disease is CPVT. This is your time. We are, as we always do though, before we update ourselves about the state of COVID-19 across the globe. Some say we're in the midst of a fourth surge. For our brothers and sisters down in India, you know it's awful right now. Those in Brazil, it is not good. In the United States, we are approaching 32 million cases, 570,000 attributed deaths. In the world, 145 million cases, and we crossed last week 3 million deaths attributed to SARS-CoV-2 COVID-19. Good is the growing number of those who are vaccinated across the globe. 1 billion worldwide vaccinations. And in the United States, we just earlier this week crossed 200 million US individuals who have received at least one vaccine. I have, Dr. Kannankeril has, and guess what? My wife texted me this morning. She got her first Pfizer vaccination. I wouldn't call her vaccine reluctant or hesitant, not like that. Maybe a little bit hesitant, but she got hers, and she texted me that she got her vaccine, first one today. So in the meantime, and until then, do all the things. Check it out. Oh, no, this side. National champions, Sikkim Bears. I'm still celebrating, but put the mask on, wash your hands, stay separated. But I will tell you, you can take it or leave it. I just saw this thing, I guess, New York Times, that said, what should you do if you're outside and you have a mask on, or outside and you've been vaccinated? Should you have your mask on? And they had these 3 or 4 scenarios. I'll tell you what mine is. I'm vaccinated. And if I'm outside, this is not going to be on. That's how I do it. It's pretty simple. And that's the way I'm doing it. The vaccines, remember, are QT safe. The vaccines are CPVT safe, Brugada safe, maybe just the minor thing. If you get a fever after your vaccine, lower the fever. Other than that, the COVID-19 vaccines are absolutely safe for our patients with our genetic heart diseases. Speaking of genetic heart diseases, now our focus, CPVT, catecholaminergic polymorphic ventricular tachycardia, for our remaining 37 minutes together. And to do that, Aaron, with your magic, let's do it. Bring on my friend, Dr. Prince Kannankeril. And there
Hello,
he is, everybody.
Hello, Mike. How are you?
I'm great. How are you, Prince?
Great.
Well, Prince is one of the gems in our field, everybody. And I learned today that Kannankeril is the house of God in translation. And so it's very special to have a man, a godly man, and to have somebody from the house of God with that name join us. So Prince, to let everybody know in SADS Facebook Live land, a little bit of your journey of how you got excited, when that happened, your journey to pediatric heart rhythm, and your special interest and passion for CPVT. How did that all come about, Prince?
Yeah, well, it's a long story. I knew I wanted to be a doctor from a young age, and I really was convinced I was going to do orthopedic surgery like my father when I started college and med school. And then it was in medical school that I realized I liked many other things in addition to orthopedic surgery. But I really got excited about the pathophysiology of congenital heart disease. And so I decided I was going to do pediatric cardiology. I did a med peds residency at the University of Minnesota with the thought that I was going to be a congenital heart disease specialist that saw children and adults. And so I entered my pediatric cardiology fellowship really still thinking that same thing. And that's when I really got first exposed to electrophysiology. And then I was like, boy, this is really cool. I like electrophysiology. At the time, 20 years ago, there weren't really adult congenital fellowships, but there were EP fellowships. And so if you want to do EP, you pretty much had to do one. So that's when I came to Vanderbilt to do my fellowship in EP. And I thought, I'm from the Chicago area. That's where I was doing my pediatric cardiology fellowship. I thought I'd do my 1 year, down in the South and then get out of the sticks. But I came to Vanderbilt and I found an amazing environment for translational research really in genetic cardiology. And so I sort of found myself, at this place that was a gold mine. I thought, if there's any way I can stay here, I need to do that. And so I started this, physician scientist track back in 2001 and have stayed here ever since. And my CPVT story really starts as a pediatric EP fellow. I was actually taking general pediatric cardiology call one weekend when the ER called me. Actually, they were asking, hey, can you just look at this ECG? And so I pulled it up and I said, it looks pretty normal, but what's the story? And they said, well, the 6-year-old girl, she passed out at church and she looks fine now, but they gave her CPR. And so, that was a big red flag. So I went down there, saw the patient, and turned out, she had CPVT. We didn't know it at the time, but, we admitted her. The next day we ran her on the treadmill and she showed, the beautiful, polymorphic bidirectional VT really just with mild exercise. And so that's kind of, how I took this long circuitous route to genetic cardiology.
Well, I'm glad it brought you here and to this place because it's really great having you as a colleague in it. You said something interesting, Prince. You said basically from the call of that child in the emergency department to the diagnosis was, if I did my math right, under 24 hours. Talk a little bit about how, unfortunately, that's not the real world, that we still have a tremendous delay in diagnosis, recognition of this condition. Why is that? And what are we needing to do about that to make that time what you described for that 6-year-old girl?
Yeah, so just full disclosure, I didn't give you the full history. She actually had 1 year prior had a seizure at school. And then, she saw a neurologist, had an EEG, it was normal, kind of given the usual spiel that kids are given, you get your one free seizure. If you have more, come back and see us. So we were suspicious that, that was something else, when she came that second time with syncope. So it, to be fair, from first symptom to diagnosis was actually, about a year. And that's, as you said, the much more common scenario. What's difficult is, these kids will have syncope or something that looks like a seizure. And if they get a basic workup, the ECG is completely normal. Sometimes there's a mild sinus bradycardia, but it doesn't really catch people's attention. If you do an echocardiogram, that's also completely normal. You really have to have a history that's suspicious enough to make you put that child on a treadmill. And then recognize the abnormal findings in CPVT. And so again, there in her case, it was blatantly obvious. She was, I think, 2 minutes into the stage 1 when she just started having incessant ectopy. Many more patients have much more milder findings. They may have bigeminy or maybe couplets that it's easy for somebody to maybe blow off if they don't know the story and if they're not suspicious for CPVT. So yeah, unfortunately, we see a delay in diagnosis on average of about 1 to 2 years from first symptom to true diagnosis.
Yeah, that's incredible. And it's an area, isn't it, where with the one area where I've seen over and over again is our sudden cardiac arrest survivors, whether they're young or old, they get put through every test under the sun because they did the cardiac arrest, they get a defibrillator. And during that whole process, nobody's ever done a treadmill stress test to even assess for the possibility of CPVT. So we certainly need to do a much better job.
Yeah, no, absolutely. And the other thing is sometimes, you know, after the initial arrest, sometimes they're not really well enough to do a full bore, you know, Bruce treadmill. So they may get a treadmill test, but they really can't go very far. And so, you know, it may not actually expose the phenotype. And sometimes it's, you know, when you sort of repeat the full battery of tests a year or two later that the diagnosis becomes obvious.
Right. Now, for that 6-year-old, after you made the diagnosis, I suspect that you then sent off a blood sample or a cheek swab or a buccal swab or saliva to do CPVT genetic testing. What's the state of CPVT genetic testing these days?
Yeah, well, so you got to remember, this girl was from my fellowship. So this was actually before, you know, we could routinely send off genetic testing to a commercial lab. She eventually did, of course, have an RYR2 test identified. But yeah, the current state of testing, you know, we get positive findings in about 60% of our CPVT patients. And of course, most of the time it's a mutation in RYR2. That's the major gene. The other gene that we've known about for a long time, calsequestrin 2, classically causing a autosomal recessive form, although now we've recognized there are patients that are heterozygotes that also have typically a milder form of CPVT than the homozygous patients do. And then there are, you know, a handful of new genes that have been identified to cause either CPVT classically or some sort of overlap syndromes. None of them are terribly common, but calmodulin, you know, 1, 2, and 3, there are 3 genes, but they all encode the exact same protein. So really a mutation in any one of those genes can result in disease. TECRL is another one of the newly identified genes. And then triaden also causes a autosomal recessive form. So again, the main one is RYR2. That's the one that underlies about half of patients with CPVT.
And with that, so when we have 50, 60% of our patients who have RYR2 mediated CPVT, for you families out there, Prince and I would call you CPVT type 1 or CPVT 1. Thankfully, number 1 is the most common. But what maybe just a little bio primer for them to know, what is that mutation in their RYR2 encoded ryanodine receptor? What is that doing to them?
Yeah, so it's a bit complicated. So essentially, RYR2 is the calcium release channel, and it's a channel that doesn't live on the cell surface like many of the channels that cause long QT syndrome do. It's a channel that is on the sarcoplasmic reticulum. So inside the cardiomyocyte, most of the calcium that's stored is in the cytoplasm, in the SR, and that is released through RYR2 into the cytoplasm when that cell is excited. So when you have a heartbeat, it starts with the electrical signal because of ion channels flowing in and out from the outside of the cell to the inside of the cell. But then contraction happens mostly because of that calcium release into the cytoplasm. It goes to contractile elements. And so patients who have CPVT have excessive calcium leak from the SR through the RYR2 channel. So some people call that a gain of function mutation, if you will, because it's extra calcium leak through RYR2. It's a bit of a complicated story. I may not tell it well without pictures, but that's basically what's happening.
That's great. So our patients have these leaky ryanodine receptors that make them vulnerable for sort of something to catch the CPVT heart off guard and trick it into going into a dangerous rhythm that made your 6-year-old patient have her fainting episode. So back then when you diagnosed her, you treated her probably with just a beta blocker, but that's not really what we're doing in 2021. Share with our friends how the treatment paradigm has changed quite dramatically over the last 20 years for treating that 6-year-old or treating that next patient who we diagnose with CPVT.
Sure. So, yeah, she's actually a great example. So, once we made the diagnosis, we started her on a beta blocker. Now we know for sure we would use Nadolol. I think back then we started with the Tenolol, and she was, relatively young to treadmill, but we didn't really have to. She had such an obvious phenotype. I would literally just walk her around the unit quickly while on telemetry, and we would see the ectopy, and then we would know we've got to up titrate this dose. Nowadays, like I said, we would start her on Nadolol, and then we would re-treadmill patients, and we really want to see a suppression of ectopy so that we don't see couplets, that is 2 extra beats in a row or more, because that's associated with subsequent events. And so we can up titrate our Nadolol until we suppress the ectopy sufficiently on treadmill exercise test. We had what we thought was reasonable suppression with her on beta blocker alone, but then I think within about a year or so, she came back with syncope, and again, this is back in 2002, 2003, and so at that time we added verapamil to her regimen because we really didn't have anything else to add, and that worked or appeared to work for some time. But then she continued to have events. And so at that point, we really had nothing other than an ICD to offer her. Now it's very different. So if I've got a patient who, despite really maximal dose Nadolol, is having either significant ectopy on their treadmill or is having events, we have flecainide. So we add flecainide, and flecainide is a really interesting story. It's a drug that we think of as a sodium channel blocking drug, and it is a sodium channel blocking drug. But it turns out it directly blocks the RYR2 channel, and it does it in a very specific way. One of my colleagues, Bjorn Nolman, has really worked that out beautifully. And it was in his lab that the discovery was made that flecainide could be efficacious for RYR2 mediated CPVT. Actually, it was first demonstrated in a calsequestrin mouse model, and when he presented the basic science data at the Heart Rhythm Society, Arthur Wild saw the poster and then immediately went back home and gave flecainide to his 2 most troublesome human patients, and it had a very stunning effect. One of the patients, he added it to their beta blocker. The other patient who didn't like how they felt on beta blocker had flecainide alone added, and so it had a very dramatic effect on the exercise treadmill test. And so we then kind of collaborated with other centers to publish our experience with flecainide in patients with sort of continued ectopy on their treadmill despite beta blocker therapy, and it's very effective. It makes the treadmill test look better, but more importantly, in follow-up, actual arrhythmic events have been decreased by flecainide. So it's really a success story, and one that we wouldn't have ever thought about had it not been for Hiroshi Watanabe, who is a Japanese electrophysiologist doing a postdoc fellowship in the lab of Dan Roden. It was his idea to do it. Everybody thought it was a crazy idea. It wasn't even worth trying, but he persisted and did it. And lo and behold, the world of CPVT is changed
dramatically. I mean, I think that's a beautiful story of true bench to bedside, where we let scientists be scientists and ask crazy questions, and then you get an observation, and then you see an early adapter like our really good friend Arthur Wilda say, hey, that's good enough for me, let's try it. But then you did something really, you're one of the giants in this area, Prince, because I think it's probably fair to say that you probably conducted one of the very few, if not only, randomized placebo trials in the world of genetic heart rhythm disease. And that was an amazing study, and it was a challenge, wasn't it? I mean, it wasn't a 1,000-patient study, and yet it was incredibly hard to pull it off.
It was, yeah. So right around that time, we thought, hey, this is perfect, because it's an old drug that actually has been around for a while. It actually was FDA approved for the treatment of ventricular arrhythmias that are deemed to be life-threatening for both adults and children, and it was something that people weren't using at all. So we thought, this is the perfect time to do a randomized trial. There should be equipoise. We should be able to recruit patients. There are a couple of quirky things about it, though. because we had a placebo arm, and these are going to be high-risk patients, we decided we were only going to enroll patients that had an ICD in place because we wanted that safety net there. We didn't want to put patients on placebo and have them die because they're on placebo as opposed to flecainide. And as you know, as I think we'll talk about, it was around that time we were also recognizing the downsides of ICDs and CPVT. The actual polymorphic VT that is the hallmark of the disease is not treated effectively with shocks. Those that go on to true ventricular fibrillation are appropriately treated with shocks, but the VT we see isn't. So we required patients have an ICD, and then most of us stopped implanting ICDs in these patients.
Yeah.
And then the other thing that was hard is, the bar is pretty low in genetic arrhythmia syndromes for evidence, right? If you see, hey, there's a paper where they gave it to 30 patients and it seems to work, we're going to start using it. We don't need a randomized trial. So we had a lot of folks who were like, I don't really have equipoise. I think I'm going to put my patients on flecainide, and I'm not going to allow them to enter trial where they have to go on placebo for a period of time. And that 6-year-old girl that we talked about, by that time, she was actually our first patient that we put on flecainide here, and I wasn't going to stop it for her because she had proven that she needed it. So
Right.
I don't blame anybody for that mindset.
Yeah, I think too. So we're at this point, I think, for everybody where one of Prince and my strategies are with our CPVT patients is we basically try to cure your stress test. We try to make your stress test look as normal as my stress test. And Nadolol, maximizing it, flecainide, and I think now in 2021, almost all of our patients, with few exceptions, are on CPVT combination drug therapy with Nadolol as the beta blocker of choice and flecainide, proven and established because of Prince's work. That you mentioned the ICD, Prince, and I'm curious. We know that basically we have a rule in our field, don't we, that if you get one death attempt, that if you're a sudden cardiac arrest survivor, you're going to leave the hospital with a defibrillator. But is that true for CPVT? If you're a CPVT survivor, sudden cardiac arrest survivor, do you think we can configure a robust treatment program for that survivor of sudden cardiac arrest that doesn't have to be the ICD, maybe triple therapy? And if so, what does triple therapy look like?
Yeah, no, great question. So, I mean, technically, the latest official guidelines for CPVT would say that if you present with an arrest, that you get an ICD. That being said, there's a lot of data that's been published since those guidelines have come out that would argue you don't need to. So, Christian Vanderwerf has led a large multi-center study looking at exactly that question for patients who present with a cardiac arrest and therefore were not previously diagnosed, who then, either get an ICD or who don't get an ICD. And this wasn't a randomized trial by any means. It was just a retrospective comparison. Those that got an ICD actually did not do better than those who didn't. All right. So with current therapy, we think we can treat patients who present with an arrest, subsequently diagnosed with CPVT. We can treat them medically and avoid the ICD. So for those patients, I basically treat them how I do everyone. I start with, maximal dose Nadolol. I look at their treadmill. If they're suppressed with Nadolol alone, I'm still probably going to do something else since they presented with an arrest. Mm-hmm. Probably either add flecainide at a lowish dose or consider left cardiac sympathetic denervation. And that's what triple therapy would be. It'd be, Nadolol, flecainide, and LCSD. And I have to say, since flecainide, that discovery in 2007, I think we've only put in one ICD in a CPVT patient, and wow. It was somebody who was having episodes. So it was a difficult social situation, and she really wasn't able to take her medications regularly, and so because of noncompliance, after her LCSD, we had to go ahead and put an ICD in as well. But like I said, we are doing everything we can to avoid it, even in those who present with an arrest.
Yeah, and so with the and you mentioned denervation, and that we probably do more left cardiac sympathetic denervations at Mayo than anywhere in the world, and I wonder if we're going to get to a point where we could potentially consider denervation and flecainide and get rid of beta blocker? In other words, should we still be looking for new treatment strategies? Because you're right. I mean, nadolol flecainide dual therapy or the triple therapy, denervation, nadolol flecainide, is incredibly protective. So why bother looking for new ways to treat CPVT? Is there still, do you think we can still do better?
Well, yeah, there's always a chance to do better. Now, again, there are plenty of patients who, all they need is once a day nadolol and they're protected. And for those patients, yeah, and if they don't have any side effects, no, we can't really do much better than that. But there are plenty of patients that have side effects that are, maybe not intolerable, but still not ideal. So, the combination of nadolol and flecainide, can sometimes cause significant bradycardia. So occasionally patients actually need pacing support just to tolerate that combination. I've got, several patients who sort of need a relatively high dose of flecainide or a high trough level to get full suppression. And they have some mild side effects like blurry vision and stuff that, again, is not intolerable, but they'd rather not have it if they could. And then there's the whole question of, what's going to happen to these patients who, usually are diagnosed when they're relatively young and they're on flecainide and, they survive into, late adulthood when coronary disease becomes fairly prevalent. So, flecainide, we didn't talk about this, but it has kind of a dark history, of course, the CAST trial, the cardiac arrhythmia suppression trial, where patients who had a previous history of myocardial infarctions, who were at risk for sudden death because they had frequent PVCs, they were randomized to flecainide or a drug very much like it versus placebo. And surprisingly, patients randomized to the drug therapy actually had a higher risk of sudden death. And so, there may be a time when somebody who can safely take flecainide now can no longer safely take it because they have the coronary disease or the MIs. And so, those patients are going to need other therapies. And, it's also not easy to take, 1, 2, or 3 pills a day when you feel fine, right? The pills don't make you feel any better. You're just taking it to lower your risk of sudden death. And, that's a difficult thing to do, lifelong, particularly for young patients.
So I think the motivation is high for us. Prince and I are trying to come up with new therapies. Thankfully, there are partners out there in industry who have become excited about CPVT and advancing CPVT therapy. I know of one company, Armgo Pharma, who has a committed program to coming up with new therapies. So for those of you who joined us, just like we've seen a huge progress from the year 2000 CPVT therapy to how we do it now, I think we're going to see similar big jump in the next 10 years. And for those who've joined us, it's great to see your names. And Karen, I'm glad you love the Baylor banner. But I did catch a question from Kayla, Prince. And Kayla, I'm so glad you're here with us. And she's asked a great one, Prince. What are your thoughts for CPVT patients who are really well controlled on combination drug therapy, who for whatever reason already have a defibrillator, and now that device is up for battery replacement? Can we abandon the ICD strategy based upon what we now know? Or do you think just because someone decided to use it, we need to perpetuate the old strategy?
Yeah, no, that's a great question because that's a very difficult decision to make, particularly if somebody else implanted the ICD, for you to come along and say, I think you're well enough protected without one. That's one of the hardest things, as an implanter to do. But again, I think the science has really changed our thinking on this. So there are lots of patients who, 10, 20 years ago, we'd say, yes, you need an ICD because, you're at high enough risk, and now we don't. So yeah, all those patients that had ICDs implanted because they presented with an arrest, and now if I've got their treadmill looking clean on nadolol and flecainide and their generator runs out, I say, we can take the generator out. We'll just cap and abandon your lead. I'm not going to expose you to the risk of lead extraction, which is, by no means a very low risk procedure. And you don't need an ICD anymore. That's been my general approach for that type of patient.
Yeah. And Lorraine, who joins us, and Lorraine, I'm so sorry that you've encountered CPVT tragedy with your sister and your son. but because of that, you channel that to do a PhD in arrhythmias. So just offers out there, Lorraine. Prince and I would love to have you in our programs for a postdoc. So keep in touch with us. We wish you the best with your PhD, and so sorry about your family's death. We're trying really hard to make these tragedies uncommon by recognizing it promptly. We know we can treat it well, and that's why we're trying so hard to develop new therapies, because preventing sudden death from CPVT is no longer a challenge for Prince and me. So we've moved the goalpost to say not just preventing death, but how do you get to live and live large with your diagnosis? And if you're hating beta blockers, then we need to come up with better. We have about 10 minutes, and Mohammed, Prince, is posing us a real challenging question. And it's basically, does the positive genetic test alone buy you treatment or compel us to treat? So he has a genotype positive under 5-year-old, no symptoms, normal Holters, even got the 5-year-old on a limited stress test, clean. So Prince and I call that person genotype positive. Yes, we see it in your genetic test, but phenotype negative. No, we can't see it on our standard tests. Prince, does Mohammed need to prescribe the beta blocker anyway, the beta blocker and flecainide anyway, or maybe not? What?
Yeah, no, that's a great question. So the first thing we got to talk about is, genotype positive. What exactly is this mutation? Is it a definite pathogenic mutation? Are there family members with clear-cut CPVT in the family with this mutation, so we know it's a real thing? Or is this a VUS and we're not really certain about? So let's just assume that it's a real pathogenic mutation, and there's family members with CPVT, and then you've got a newborn or somebody under 5 who has the mutation. I typically do start those patients on Nadolol. That is, again, the official recommendation that genotype positive, phenotype negative patients are treated. And again, in the young ones, at least in my practice, the families tend to welcome that. They think if this offers protection, then I want to do that. And then kind of there's the other end of the spectrum. You've got the adult relatives who are genotype positive, and you can put them on a hardcore treadmill and they have no ectopy at all. The recommendation is theoretically still for beta blocker for those, because they do have a slightly increased risk. I will say that I find very few of those adults who want to take a beta blocker. They've lived at least into adulthood, and they feel like nothing's ever happened. I don't want to start a new medicine if I don't really need it. And you've got some of these people that surprisingly are high-end athletes. I've got one family who has a clear-cut RYR2 mutation. The proband is affected. His mom is affected. His brother has the mutation, has mild ectopy on treadmill, not even real, not even by Gemini. And he was playing, Division I college athletes. So he sort of proved himself to be low risk. But getting back to to this question, do you need to? No, you don't need to. Although that would be my recommendation. It wouldn't be triple therapy or combination therapy. It would really just be Nadolol at 1 per kilo, because we've already got an acceptable treadmill in that case.
Right. Yeah, and I think, Mohammed, it is, I agree with everything Prince said. It's kind of a stay tuned, though. We recently published our experience with what we call intentional non-therapy in long QT syndrome, where we know it's there, and we're choosing not to treat, where we weighed the risks and benefits in the balance. And we actually have started to do exactly the same thing in that patient that you're describing, Mohammed. And so we have a growing series of patients who are going to teach us, because they're wanting to do this trial of non-therapy. So most of my patients are just like Prince's families, where they say, no, we'll start the beta blocker, but some aren't. And we'll see whether that was a wise idea or whether that was a tragic mistake. So Mohammed, stay tuned on that. I think a careful discussion with your family, and you'll come together with the best treatment configuration. Great questions coming in. maybe we'll take two of them here. I just saw it from Bert. Wants to know a little bit more about the left cardiac sympathetic denervation. What is its success rate, and does it have complications? And that one's a great, I don't want to delay that one, Bert, but maybe we've had so many questions about denervation therapy that we punt that one down the road where we can develop a longer program to all the nuances of denervation therapy. And so I saw your question, don't want to ignore it. But let's do this one from Serena Prince. Do you order the genetic test on the inpatients or diagnose clinically in the hospital and then delay the genetic testing until the outpatient? I think I know your answer, but give it to Serena.
Yeah, it's a little bit of a moving target. We traditionally had done it as an outpatient, just because that's how the billing worked at our institution, and that's changed very recently. So we much more commonly get it as an inpatient now that they're not, as soon as we can, we order it, which is usually in the inpatient side nowadays.
And we've talked a lot about all of the therapies that you and I use. What about a different drug for Rapamil that's being asked, or a calcium channel blocker? Do you use it? I can tell you, I think I might have used it once in my own practice. Do you use that one, or is that not part of our treatment?
Not anymore. If you're in a part of the world where you don't have Nadolol, you don't have flecainide, and you've got limited options, that might be an option. We used it for that 6-year-old girl because that was kind of in the pre-flecainide days, but again, the long-term data on calcium channel blockers and CPVT is really not very promising. So if you have, beta blocker and flecainide as an option, that would be better.
And Prince, I'm going to give you the final 4 minutes before I say goodbye to answer Lawrence's question and weave it into, I'll give you mine. His question is, what is to come in the future for CPVT? And then mine, to follow up with Lawrence's, is what 2 questions are you vexed by that you're trying to answer, that you want answered for our CPVT patients in these next 5 years? So what's to come in the future overall as you see it, and 2 burning questions that you want answered?
Sure. Yeah. Well, so, what's to come, Mike touched upon, some of the new medications that are being developed. And so it'll be interesting to see sort of how those compare to our current armamentarium. Of course, gene therapy is something that is a very exciting possibility in the future for CPVT. There's a ways to go, but if that was an option, then we wouldn't have to worry about, different medicines and operative procedures or ICDs or anything. In terms of sort of questions that I'd like us as the field to sort of address. I mean, one of them is just, what underlies the different severity you'll see even in the same family with CPVT with the same mutation. You've got some people that have, very mild disease, and then you've got some that have, very florid disease, and it'd be really interesting to find out what all is modifying it. Is it other genes? Is it something in the environment? Who knows what that is? But that's a question that just has always kind of puzzled me. And then the other question, and it's kind of an obvious one, is what's causing that other 40%? The genotype negative, right? I mean, we found a few other genes, but they're not all that common causes of CPVT. So is this going to be something that is more polygenic, or oligogenic, like Brugada syndrome and a subset of long QT syndrome? Because that's a pretty sizable cohort of our patients. Almost half, or I guess slightly less than half, we really don't have a genetic answer for them. So that's something that Mike will probably be leading the way on in the future.
We've been stuck on that 60% number for a lot of years, haven't we?
Yeah.
Well, Prince, on behalf of SADS, Facebook, Live Land, and whether all of you out there have been joining us from Facebook or Twitter or YouTube for episode number 16, give a virtual thank you to Prince Kannankeril, also known last name as House of God. So Prince, thanks for joining us, and thanks for all you do for the SADS Foundation, for the families that are under your watch. You are a special physician, and a very special translational scientist trying to come up with the answers for tomorrow. So appreciate you. Thanks for everything.
Well, thank you, Mike, for having me, and thanks to the SADS Foundation and all the wonderful work they do. Just, the more I learn about SADS, the more impressed I am. So thank you all.
And for all of you out there, join us next week. We're going to have a really good program, really good. It's dedicated to ARVC for our families with genetic heart disease due to arrhythmogenic right ventricular cardiomyopathy, or ARVC ACM. Brittany Murray from Johns Hopkins, a genetic counselor there, is going to join me, and we're trying to provide some updates on the latest in ARVC. And then 2 weeks from today, a special Mother's Day celebration, and Mother's Day is every day, but we're gonna celebrate it especially in 2 weeks. So until then, I'll see you next week. Have a wonderful weekend. Take care, everyone. Bless.